Welcome back, everyone. This is it, our final class. It's Thursday, December 3rd. And it is really an honor to welcome you all back. And I have to say, before we get started, I'm gonna pull a surprise on Allan, which is to thank him. This has been the privilege of my career in many ways, to get to work with Allan and to share with you all this moment as someone who is trained in infectious diseases and invested in thinking about pandemics. That's been really a focus of my career. To have this moment to share it with him and you all and the tremendous team that we will thank at the end of this session has been so deeply gratifying, even though the subject material has been incredibly painful for so many of us. So I want to put that little surprise thank you in right from the get-go. And thank you all for hanging in there with us twice a week and then in section. It's a lot, and it's a lot during a time that's deeply challenging for so many people. And we really, I know both of us really want to recognize that. And today we're really going to be unpacking this course and thinking about this moment together and trying to share with you some of our thoughts about this moment in the pandemic. But before we launch into that, without trying to give you any information in advance, we're going to start with a poll, since we'd love to hear where you guys are. So without further ado, I'm going to ask Evan to put forward our poll for today. And you can see there are 4 questions today, so take your time with them. Okay, so let's talk through these for a minute here. The first question relates to proposed financial incentives to ensure high rates of vaccination and whether people would support this. And over almost 2/3 of you said yes. And I think that this is an interesting reflection on kind of many issues related to incentivizing people. And we can talk about that some more, but 2/3 said yes. Would you want to be vaccinated as soon as you can be? So overwhelmingly, yes, 77%. The third question relates to whether vaccines should be made compulsory for the entire population. Again, a very large percentage, 70% said yes. And then the last question is, have you ever been hospitalized? So that is actually close to 50% of you. And I think that's, and this is, again, we wanted to know if you've ever been hospitalized for any reason, and we'll talk a little bit more about why. I think that before I pass it to Allan, I want to just speak to this moment today statistically, and speak about that last poll question that you all answered related to rates of hospitalization, because Allan has often said that in the numbers, we really miss the experiential aspect of what has happened to people and what it continues to happen to people. And I know as a physician, I have seen when people are hospitalized, both that we have an incredibly high threshold to hospitalize people. It means they have to be incredibly sick to warrant hospitalization. And secondly, how disruptive and painful that experience is for people and how exposed they are in so many ways. And so in that context, when we talk about the data that came in yesterday evening, that more than 100,000 people were hospitalized yesterday alone for COVID, I think we somehow are distanced from the individual aspects, that each of those people have people who love them, and each person has an experiential aspect to this pandemic, over 100,000 in one day. And I think, again, the statistics of the day are not necessarily reflective of our collective experience. And that's part of what we want to talk about today, which is the collective experience of this pandemic. And despite these numbers, there's also promising signs on the horizon with vaccines, as we've talked about. And I think these are all things that we're going to unpack today together. So let me hand it over to Allan, who will share his words.
Thanks, Ingrid. And of course, thank you for thanking me. I hadn't anticipated that you would begin the course that way. And I just want to tell you how strongly mutual my feelings are about that, and how much I have appreciated getting this chance to collaborate with you on the course. And of course, just how much, you have contributed and meant to the development and the implementation of the course. And it's really been, a, career pleasure for me to get to do it with you and to get to understand how you think about your work and treating patients and thinking about problems of infectious disease and global health. So I just want to say how fantastic it has been to have this opportunity to work with you and learn with you. I also just wanted to say quickly a little bit about last classes. Ingrid asked me this morning how many times, I have had a last class, and it's probably somewhere around 100 last classes. And I always find myself anxious, frustrated, trying to figure out, how to conclude something that's been so important to me, and to how to think about, what it is that I want to try to communicate in the last class, because there's always so many loose ends, and there's always so many things that I felt, well, we didn't go into enough detail about, or things that we left out. And as I think everyone understands in this moment around COVID, as comprehensively as we've tried to look at the pandemic, it's impossible to encompass all of the significant science and social and political and cultural aspects that an epidemic runs right into. And so Ingrid and I worried, like, what can we do? How do you end a class when, in a way, all of our teaching is always about, trying to develop strategies of thinking and knowing that continue. And it's especially significant now because this has been a class in real time about something that's happening, and it's going to continue, long past the end of this particular course. So we thought a lot about that. And I had this one other thought, is that, I've never taught in a remote situation before. And so, like for all of you, this has been a entirely new kind of experience. And I was thinking about the affect in the room when I would come into a last class, and that I would have a sense of knowing everyone in the class, even in a big class, and to some degree they would know me. And that's been very difficult this year. And I found myself thinking back about so many of the talks that we heard in the class. But as I was thinking about that, I was thinking about Diane Paulus's talk just a week or 10 days ago, and the notion of live performance. And obviously don't think of teaching as live performance, but it has this similarity in that we're all in the same room together, and it happens live, face to face. And that's something that is incredibly gratifying to me about teaching that wasn't possible during this term. And I don't feel like I know you as a class or individually nearly as well as I would have if we had been meeting in person. And that's a loss for me. It's not a, it's nothing compared to the losses that people are experiencing now. But I do think it's helpful to understand what we've been through. And I want to understand better, what you're going through and what it means in terms of your education and your futures. And this has been an incredibly unusual time. So one of the things we thought we would do is to just reflect a bit, focused on the pandemic, of what things look like kind of when we got started in September and how they look to us now at the beginning of December and the sort of anticipation of 2021. So Yvonne very helpfully prepared some slides that will help us talk through this. And I'm not sure what they are completely. So yeah, where did we start? Where are we now? And what's changed? And I think it would be good to reflect on that because change has been so accelerated during this period that there are some things that really have changed just in the months that we've been meeting. So, we're all hopeful about vaccines. And we're seeing the development of vaccines in really record pace. It's just been a remarkable aspect of our science that from really February 1st, you might say, even back into January, to December 1st, science globally has been able to produce, perhaps a dozen vaccines, two of which are incredibly promising and about to be publicly distributed here in the US. And you probably saw yesterday, the UK actually approved the Pfizer vaccine, and it's going to begin to be distributed by this coming Monday. It's just unparalleled. And it's a remarkable achievement. And it speaks a lot to sort of the development of sciences in the 20th and the 21st century, and the potential for truly safe and effective preventive vaccines. So I don't know if you have a thought about that, Ingrid, but
I think to your point, Alan, I think we are at an unprecedented time in terms of our scientific achievements. The platform that these particular vaccines that are coming out is an mRNA platform, as was discussed in our vaccine session. And to date, there has been no vaccine that's been offered to a full population using mRNA platforms. And I do think it speaks to the novel technology that's happening here so quickly. It is truly unprecedented. And, I think we have all lived through a time where we have relative health in the last 50 years or so, between the advent of successful antibiotics and, of course, the effective vaccines that have prevented so many illnesses in childhood and in our adulthood. And so I think this is another moment. It is a moment that we will reflect on for many years to come, I believe, in terms of the unprecedented pace and development of these vaccines.
I have one other thought about this, which is that if you had asked me on September 1st, would we have vaccines ready to actually distribute on the 1st of January, I would have said, well, I'm actually skeptical about that. I know that there's a lot of hope. There's intensive research going on. There's very brilliant minds working away at this. But the pace has surprised me. But I was talking with Allan Garber, who was in the course very early on, and he explained something that should have been clearer, that one of the reasons why the vaccine trials went so quickly was because COVID was so prevalent and surging. And people need to be exposed, and part of the problem of these trials or difficulties of doing them is some people got placebo. And the way we know the vaccines work is because people with placebo got COVID. And if COVID's not so prevalent, then fewer people get it. And it takes longer to find that the vaccine is safe and effective. So part of the irony of knowing that we have effective vaccines now, and I really believe we do, and that they'll be successful, is that the pandemic was so significantly uncontrolled during this last 6 months. So when we see the success of vaccines, we have to also realize that they are deeply interpenetrated to the actual uncontrolled pandemic and, in the US, but also around the world. What's next, Yvonne?
Yes, so clinical treatment trials. So we had a session on this and treatments, and I think we have learned so much in the last 6 months. I think the telltale sign of this is that despite the enormous number of hospitalizations, fewer people are dying from COVID in terms of case fatality rates as compared to March. We know how to care for patients better who are hospitalized with COVID. It's not to say that we still are in need of more treatment options. Certainly, particularly for people who may be presenting with milder symptoms, but have the potential to accelerate to worsening disease. And so these are a compilation of some of the trials that have been done. And the rule of thumb is usually that therapeutics, or these, as we say, clinical treatment trials, get developed faster than vaccines. Because again, we're starting from scratch when you think about creating a vaccine de novo, whereas a clinical treatment trial, particularly in critically ill patients, we're pulling things off the shelf and trying them. So these are not medications that have to be manufactured. They are already in use, perhaps for other clinical purposes. And so in general, we tend to move much faster in therapeutics than we do for vaccines. I think one of the interesting things about this moment is it's actually somewhat reversed in the sense that the vaccines were just completely accelerated. And we have, again, found better ways to care for patients with advanced COVID. But we still aren't quite where I thought we would be at this point, where I really thought we would have effective treatments for people with mild symptoms and certainly more effective options for people with advanced symptoms. And what we know is an old standard, dexamethasone, is effective if you have advanced disease or advanced symptoms from COVID. And even something as simple as making a patient prone or flipping them on their abdomen if they require ventilation is very effective. And that was a bit surprising to me. I thought we would be further along and perhaps have a whole suite of options we could offer. And thus far, we have been somewhat more limited in those options.
Let me just ask you a quick question, Ingrid. If you were treating a COVID patient today, are there any new treatments that would be accessible to you that have been developed during this last 8 months of the pandemic?
Well, I don't think there's been new treatments that we could pull off the shelf. I do think there are hints of things that certainly are promising, including the monoclonal antibody cocktail. I think the issue, of course, is a lot of these require infusions. And so if someone has mild symptoms, it's not exactly a feasible option to bring them in for infusions. And I would say in many ways, we have improved our ability to care for these patients. And certainly if they're hospitalized, we know something as simple as providing them oxygen, making them prone, turning them on their abdomen, and of course, giving them dexamethasone are all critical pieces. And that would be certainly in the book of things I would have for patients presenting to the hospital. But there hasn't really been, I thought there might be some more innovative solutions, particularly because we have so many therapeutics that really impact our immune system. And so much of what we see when people have severe symptoms is that their own immune system is fighting them, that it's revved up against this virus. And so they rapidly deteriorate. And I had thought with all of the various therapeutics that we have out there that really target the immune system, we might have seen a few more options in our armamentarium. And I don't think we have seen quite that come to fruition yet.
It is a really interesting issue because, we tend to think of treatments as specifics versus non-specific treatment, which would be, turn a patient over on their belly or give them oxygen or make sure they have enough fluids and don't get dehydrated. And people continue to respond to those kinds of treatments. I was very struck. I've been reading Paul Farmer's new book on Ebola. And as you know, no one who returned to the West and was treated in European or American hospitals really died of Ebola. And there was no Ebola treatment, but they got non-specific care that typically rescued them. And it was really, in Paul Farmer's judgment, and of course he came to class, that really oral rehydration saved patients' lives in West Africa, but it was the unavailability of a non-specific treatment that led to such disastrous numbers of deaths there. Yeah. And so there is this ongoing question about, specific targeted therapeutics, which is characteristic of some of the immunologically active drugs that are available versus being able to take care of people. But, one of the things we heard in the course is just how complex COVID is as a disease. And I think it was Zuri Song who said to us, he's never seen something where an infection, one person, they have no symptoms at all. And in other people, it's going to be their cause of death. And that variability clinically, obviously on a gradient of age and other health conditions, but that you could have two young people infected and one would have a disastrous outcome and one would never know that they had been infected.
I think if I were leading a line of research, that's exactly in this area, that's exactly where I would point my North Star, because I think that is a really critical area we don't understand. We know groups of people who are at higher risk for poor outcomes, but we really don't understand these individual differences and what makes one person have a poor outcome that looks just like this other person who, doesn't even need to be hospitalized.
That's really a critical remaining uncertainty after this first year of the pandemic. Let me just mention one other thing. The lines are open. So if anyone has a question anytime during this hour, we'll be taking questions and hoping to get some of you on. So I forgot to mention that at the outset, but we're not waiting for questions till the end. And if you have questions or thoughts or comments, we are eager to get you into the conversation. Let me just mention one last thing about these treatments, the monoclonal antibody treatments that, as we know, President Trump got when he was hospitalized at Walter Reed, are incredibly expensive. And vaccines, it looks like, will be relatively inexpensive and paid for. So that's one more thing. We don't need to belabor it now, but the expense of new treatment seems to be one of the principal issues that will be a reason why people don't get treated, even if these treatments are highly valuable. So
on that note, we actually do have a question
Right.
from one of the students. Do you think focus on vaccines and how much we socially invested in their promise compromised the development of clinical treatments?
I can try to feel that one. I don't believe that to be the case. I mean, I have other thoughts about the focus on vaccine development, particularly when you compare it to investment in public health, long term, and particularly now. And I do think public health just hasn't had the same level of investment in general, and certainly not now. But I don't think that the focus on vaccines has necessarily compromised the focus on treatment. I do think that clinicians in the hospital have actually had an unprecedented level of collaboration and researchers to accelerate trials related to treatment. It's just that we haven't quite found the successful story yet. It's certainly better than it was, but it's not a slam dunk. Allan, thoughts about that?
I do have one thought about it, which is that I know some clinical scientists who are doing trials on treatment, and it has proven much more difficult in some ways to mount those trials because you have to recruit people who are sick with COVID. And the vaccine trials proceeded very quickly because they were really essentially fully healthy volunteers. And so one of the things I think we need to think about when we think about clinical research is the complexity of conducting trials on people who are already sick. And it's much more difficult to collect those groups of people, to make sure they're consistent, to understand the data, because they may die, but it might not be, a result of the treatment, or it may not be a aspect of the treatment not being effective. So it's been very hard. A lot of these trials are going on in nursing homes, and you can imagine some of the structural problems of developing treatments. We know this from cancer chemotherapies. The subjects are experiencing cancer, and it's a very complicated population to recruit and to observe and to learn from. So there are some structural problems and some contextual problems in the difference between therapeutic development and vaccines, I think. You know more about that than I do, Ingrid. So.
All valid points. All valid points.
One really good thing is that patients who get care are doing better. So maybe you want to say a little bit about this, Ingrid. And we have a question. Do we have other questions right now, Ivan?
We have one. I think I might know how you'll answer it, but you mentioned how unusual COVID-19 is, especially in that it affects people so differently. Do you think it came to life coincidentally, or is there any chance it was created in a lab somewhere?
No, I don't think it was created in a lab. I think this is just, this is what occurs when we have human existence. We've seen Allan, as a historian, can speak to this much better than I, but this is just the human existence, that there are, particularly in the interface of human populations and animal populations, but certainly overcrowding. This is, and I think we had a few sessions actually related to this, that this is far from unique in our history, as was alluded to by multiple speakers. Allan, any thoughts on that?
I do have this one thought about it, is that, I've tended not to see disease as some sort of natural phenomenon. And so when I see these zoonotic infections becoming, a higher risk, then I think it would be sort of incumbent upon us, and this is something we might have talked more about in the course, to examine what are the conditions, what is the environment that is leading to infections crossing between animals and humans. And if you look back at MERS and H1N1, and they all have sort of different origin stories, but a considerable problem that we're going to need to address in terms of global health is the environment, ecology, the relationship between humans, animals, agriculture, and the planet. And so I tend to see COVID, looking from 60,000 feet, and we talk about preparedness. There've been a lot of concerns about so-called wet markets as a potential risk for infections crossing into humans. There's considerable evidence that this virus affects animals and did pass to humans. So I tend to think that if you really want to talk about preparedness, you have to talk about cities, poverty, diet, food production, agribusiness, the end of the rainforest. So all of these things are affecting our health. And coming back to what Ingrid said, we've lived through an age of impressive health, especially in the global north, where we were relatively free of epidemics from really 1900 to at least HIV, but now 2020. And I think that in terms of future thinking about global health, we're going to need to think more about what some people are calling planetary health and the larger ecology of humans and microorganisms and how to, make ourselves safe. So we can be pursuing vaccines on the one hand for specific organisms, but we also have learned how hard it is to control an epidemic when it really takes off. How could we reduce the number of epidemics and their severity by thinking more concertedly about planetary health? And so there's a small movement for this, but I don't think that we can just say, well, who knows where this started and why, but we have to deal with it. Obviously we do. But treating it as a natural disaster or a perfect storm seems to me to undermine the kind of research and thinking and care in which we structure a variety of critical relationships for health. So it's actually quite an interesting question.
Yeah, well said. So this slide that we have here, I think, speaks to the conversation that we've just been having about survival. And I think the takeaway point from this is, first of all, we know when there have been high levels of exposures that about 2 to 3 weeks later, we're going to start to see an uptick in hospitalizations. And then about 2 to 3 weeks after that, we start to see an uptick in mortality due to COVID. That's been the general pattern. And certainly that's something you can see reflected here, that those rates have been true throughout this. I think what, the key point I want to impress upon people is that deaths are dropping as compared to hospitalizations. And that speaks to the point we were just discussing, which is clinicians and other frontline providers that work in medical centers have been better able to care for patients. The one exception that I feel like I need to put a caveat out there is when hospitals get overwhelmed. And early in the pandemic, as we all know, New York City and New England was hit incredibly hard. And at our hospital, we discussed the fact when we had our sessions that we had to prepare for what we called surge planning, which means we have too many patients per available bed. And I think there's been a lot of discussion of what per available bed means, because it's not just a physical bed, it's an individual who's taking care of these patients in these beds, particularly in intensive care settings where you have much more of a one-on-one or maybe one-on-two care environment. You have to have incredibly well-trained and well-skilled individuals caring for these patients. And so when you have the capacity to meet those needs, then our ability to address symptoms of COVID is much stronger and more robust. And, I think one of the things that's come up is if we continue to surge as we have over the next 2 to 3 months, hospitals will likely continue to be overwhelmed by patients. And then no individual provider can reach their full potential, of course, in terms of providing that level of individualized care that is essential. And so again, this speaks to the need to really focus on prevention and keeping people out of the hospital as best we can. Allan, any other thoughts on that before we move on?
I think we should move to this
Okay.
next slide.
Epi. We liked this because it showed that the whole country has been impacted. Wherever you are right now in the country, you have most assuredly been impacted. Your town, your community has been impacted by COVID. And as I alluded to in the beginning, we saw New York, New England, East Coast, West Coast had a cluster of cases. And then it really became the Sun Belt and then shifted up towards the Midwest and the West and the Dakotas. And so you can see where we were as of last month, that it was really the middle of the country much more impacted by this pandemic. And I wonder, Allan, if you have any thoughts or comments about that.
I guess when I see these types of animations, I can't help but think that they kind of really represent sort of our ability to visualize data in 2020. And you never would have seen a chart like this, for HIV. We just didn't have the digital technologies or, the software and the capacity to make a chart. And the pandemic has made me think a lot about visualization of data. Some of you may know the classic works of Edward Tufte, who made early studies of how graphs and charts could represent data or even misrepresent data. And the important maps that John Snow, the physician epidemiologist, drew of the cholera epidemics around the Broad Street pump in London in the 1850s. So I thought, what a great project in a way to evaluate the charting and the graphs and the animations that the pandemic has represented, and how even, one of the things we always worry about when we try to visualize data, are there other ways that sometimes it doesn't represent? And Ingrid and I have talked a lot about, sort of the relationship to seeing a chart like this and the intensity of the pandemic through the center of the United States right now, and what this means on the ground in terms of people who are sick and their families and their local hospitals, and what the demands that a pandemic like this places on people and the people who might be able to help them.
Absolutely. So these are, again, this speaks to where the United States is in the context of a few other countries in the global north, in the European Union and the UK. And you can see here how the US just continued to accelerate. And I think, again, France certainly had an unprecedented level later on, and then peaked and came down. We have had a steady trajectory upwards. And I think many of the points of discussion that we've had, particularly epidemiologists and public health experts, is what could have been avoided. How much of this needless death and losses could have been avoided with effective prevention and mitigation strategies. And we know now the effectiveness of mitigation strategies, the need to wear a mask, the need to stay socially distanced, the need to meet outside as opposed to indoors where we know transmission is at its highest. And so again, I think the graph and the graphics always belie the facts underneath of the human suffering and the human condition in it.
Let's go on. Are there questions in the queue?
No, I don't think so.
Yeah.
Yeah. I think that, you know, when you see those charts of how poorly the US has done, there will be many historians looking back at our really, you know, incredible difficulty of mounting testing systems and getting people tested and, you know, ease of testing. I was really struck by this, and, you know, many of you traveled over the Thanksgiving weekend to return home, and the lines that occurred in so many places here in Cambridge, but around the country to get testing really speaks to a fundamental failure. We've talked about vaccines, we've talked about treatment. Testing really should have been up and running very quickly. And we actually have those technologies, and we could have developed them even more strongly. And there's no question the United States could have made them far more consistent, accessible. And I couldn't help but be struck at Thanksgiving. There were two sets of lines. One was for testing and the other was for food. And they were not unrelated. When I see this photograph of the cars snaked around waiting to get COVID tests, I had this one thought, you know, is that a COVID test line or is that a food bank line? And those two things are related.
Yeah.
And I think that when historians look back, the story of how the CDC failed to produce an effective test in a timely way. And the testing issue also makes me think that we sometimes forget how difficult it is working in real time, that every week that you miss actually leads to those charts of hospitalizations and deaths going up. So the idea of like, well, you know, this will unfold is that people who are working in epidemics are working in real time. Delays have real human costs that are profound. And this will be, you know, one of those things that when we look back on, we might say, well, therapeutics and vaccines, you know, those are hard to roll out. But testing was the critical mitigation tool that really was so inconsistent that really, you know, has continued to lead to so many problems. I got an email yesterday from Quest Diagnostics. It was it was an advertisement, and it said that Quest Diagnostics testing is discounted for, it was like a, what do you call it, Black Monday. And they were putting their tests on discount. And early in my career, I'd had sort of the notion of the business aspects of medicine, you know, kind of, you know, we're discounting coronary artery bypass surgery this week at this hospital, you know, get it and get yours now, you know. And there was something so striking about, you know, the idea that a lab, a for-profit lab, is discounting medical testing, and you could buy these tests in advance, you know, like, what are you giving for the holidays? I'm giving, you know, a dozen COVID tests. I bought at a discount. And there's something funny about it and very strikingly, you know, problematic about the, you know, why we failed, and many countries succeeded in this way.
And I think it speaks again, as you said, Allan, to the fundamental inequalities in our society, the fact that a testing line is as long as a food line, or the fact that people who had access to resources could perhaps buy a whole slew of tests when we have the NBA getting tested regularly and school children don't have access and their teachers don't have access to testing. Really speaks to where the investments have been lying in the United States consistently, and also the fundamental inequalities that exist here.
It's going to be a very big issue because even with vaccines, we really still need to have massive testing. Danielle Allan, who came to the class, her group at the Safra Center, working with Rockefeller, developed a notion of, 5 million tests a day, and we haven't gotten close. And you may remember Michael Minna visited the course, and he wanted everyone to be able to test themselves at home, even with tests that were imperfect, because this would be the crucial strategy. And I'm still hopeful that we'll see this in the coming year. Minna recently wrote an article after he visited our class that we could end the pandemic before Christmas. And I would look back to see when he wrote it, early November. But he said, if we just could supply the technologies that we have, we could do so much better. So this is an enormously frustrating aspect of the history of the pandemic, especially in the US. Let's move to another slide.
Yeah. Misinformation, our last class before this one. So this one, as we discussed, has been a really critical factor in this pandemic. And I think many pieces were highlighted from that section. But what I would say, as I said before, is that misinformation has been with us and it will continue to be with us. I do feel that this time there's been someone has put their foot on the gas pedal of misinformation, and it has had deadly consequences in our country. And
I know who did that. It was President Trump.
I think that you cannot deny this administration's role in spreading misinformation. And I think that unfortunately, misinformation works best when it's contagious. And so, of course, if someone were to propagate this message, but it weren't necessarily picked up, that would be one thing. But this has obviously had a tremendous impact on factors such as mask usage, the role of social distancing, and so many other areas that we know are effective for mitigation. And so I think that this has been a tremendously challenging time for people who have tried to step forward and put accurate data out there in front of populations, because there may or may not be traction there.
Got a couple of student questions if you're interested.
Great.
Just pull Oliver up here. I'd be curious to hear the professor's comment on the CDC's newly announced priorities for who should get the vaccine. Would it be more effective in averting deaths per dose to vaccinate nursing home staff and put additional doses elsewhere than it would be to vaccinate all nursing home residents? What should I say to my peers who think that people in their 20s should be prioritized for vaccines if they're the least likely to comply with these stay-at-home orders?
Allan, would you like to start to answer that?
I think these are going to be really tough questions. And, it's part of a social, political, and ethical debate about how to, put vaccines, into our population, especially during an early phase when they will be in much shorter supply. I think that I was thinking about this, like Ingrid's likely to get vaccinated probably first of anyone in the class. I'm somewhere farther down the list, and that, I was thinking about, the students in the class, you're going to be very late in the year. in terms of getting vaccination. So there's some logic to the maps that the CDC has put out. States will have their own choices to make about how they want to use the vaccine they get. So again, we haven't really had a national discussion and a really completely full discussion about how to do this kind of, resource allocation. So it's a really great question. And of course, it's been laid out at least first that frontline health providers and, nursing home residents and staff, I think, are at the top of the list right now.
Yeah.
Ingrid, do you have a thought?
Yeah, that's right, Alan. And I think, this comes out of what would be considered a neutral body. The ACIP put these recommendations forward to the CDC. The CDC has adopted those. It will be a state-by-state decision in terms of allocation. So while generally most of the states do tend to follow CDC guidelines, it is really up to the states in terms of how they're going to allocate. And I think this speaks a lot to the issue of scarcity and the need for abundance in this moment. And the prioritization of certainly of nursing home, people who live in nursing homes is, I think, extraordinarily justifiable because they have by far had the highest rates of mortality due to COVID. I think the role of frontline providers, and we'll get to this soon, is a complex one. I think certainly healthcare providers are amongst the people who are on the front line and doing this work. But again, I think that there are many people who would be considered frontline providers and certainly should be early in this course for getting vaccinated.
And the follow-up, what do you think of the fact that 80% of the vaccines produced in 2021 are spoken for by a handful of developed countries, while the rest of the world will be fighting over each other to get the 20% left? Those developed countries definitely played a huge role in investing in these vaccines and led them to become available this early. How does one reconcile that with their values and belief in equity?
Giant issue.
Yeah,
And,
huge.
one question would be, how we allocate vaccine in the US in relationship to our concerns about the pandemic in the world and less served populations. And, how one of the things this speaks to is like vaccines are fantastic and they're going to be protective, but the way we decide to give them and to whom we give them will be an incredibly complicated political and social process. And, I do think there's going to be high pressure in countries like the US and the UK to vaccinate everybody first before shipping vaccine out. And this comes back to an issue we raised in the course earlier about global governance. Should there be a global process of vaccine allocation, or should we be thinking about these resources on a nation by nation or even state by state basis? And these are profoundly important issues that will not just affect COVID, but many other diseases looking ahead and many other medical technologies and resources. So I'm very glad that you raised that question. But as you know, the United States didn't sign on to a global pact about vaccine distribution. Personally, I'm hopeful that we will be able to target vaccine to places that need it most, as well as people who need it most.
So I think in the interest of time, maybe we'll move forward to our subsequent thoughts.
Let's go. We can go a little quicker here.
Yeah, let's move to our keywords.
Let's go to the keywords.
So I think, all of you in the course got an email sent to you to ask you to think about 4 keywords. And maybe I just want, if Allan, would you be so kind as to take a minute just to conceptualize what we mean by keywords in this moment, because I think this is a critical aspect to the class.
Yeah, I've been thinking about it in sort of two ways. One are what are the words that jump out to us, like vaccines, in this misinformation is right at the center. But there are also another way of thinking about keywords, one that a very brilliant mid-century social scientist, historian had thought about, named Raymond Williams. And he thought about keywords not in the idea of like as a referencing point or indexing or words that occur more frequently or less in a particular time, but words that were highly resonant for contextual and cultural explanation. So I think these words work in different ways, and this is an unbelievable, word cloud. I really like word clouds because they kind of like, you can really understand something about words that dominate over others, words that are included, words that are left out. But Ingrid and I have been trying to think about some key words in the context of Raymond Williams' notion of words that resonate and help us potentially to understand something fundamental, and often the term I use is have a strong valence. So we just want to run through some of these words very quickly. They're words that will be familiar to you in large measure from the course, but as we were talking about this, we said if we were writing a book on COVID-19 and each chapter had these words, we could then explore complicated aspects of the pandemic from just starting with these words. So why don't you start, Ingrid? We have 8 words that we would propose, some of which may be embedded in here, but words that we think capture some essential problem of the pandemic, that resonate in a way with a more generalized or analytic account of the pandemic.
So my first chapter of this novel would be Frontline. I speak as a physician and one who's had to face my own fears about caring for patients during this time. I told a somewhat revealing story to Allan. My birthday is in March, and I was trying to figure out if I should buy myself some sort of hazmat suit or something of that nature for my own birthday. That speaks to the fear and the recognition of a place that I had never experienced as a physician, which is the concern that I had for my health and safety and caring for patients. And I think I'm not alone in that. And I had a large network of colleagues and friends whom I spoke with about their own concerns and fears. And again, this is not something that is a theme of certainly how I have practiced medicine since I've been trained, and certainly not something that many of us in this generation have experienced. I think the idea of frontline has a few different meanings here. So frontline is certainly something that we have come to associate with healthcare workers and the recognition of that. I think back to images when people were out on their patios and their decks in New York City, ringing bells, and how that resonated so poignantly for me. I also think about the idea of a front line of workers who allow us to survive and thrive in our society, whether those are people who are stocking shelves in pharmacies or providing us with nutrients. And I also think about a front line, of course, in a more militarized setting. And I do think there's been a real militarization of this, kind of the fighting of it, that may or may not be warranted. And I think these are terms that have a lot of meanings in them, and ones that I feel have been really critical for us. And certainly we had quite a few conversations in the class with people who we would say are frontline providers. So that's my first chapter. Allan, what's yours?
One of the words that really impacted me in the course was the term nihilism. And, there's a long history in the history of medicine about sort of a term called therapeutic nihilism, where physicians in the 19th century got skeptical that a lot of the really terrible interventionary strategies they were using with patients were really harmful, and they became more skeptical. Sometimes nihilism is associated with skepticism, but the idea that there's nothing we can do. And, this is often an idea that is directed especially at the poor or at racially marginalized groups or the subject of racism. We can't fix that. We can't do anything about it. And the idea that you would just let a pandemic go and say, we can't do anything about this now, really has been one of the most striking and outrageous and sad aspects of this. So I found myself thinking about this. We often say, well, this is just too expensive, or the cost benefit calculus doesn't add up. It would be too expensive to do that. How are we going to get testing into everybody's homes? And every time we have those thoughts, like we can't do this, and it turns into this nihilistic view, that's incredibly disappointing, and it undermines everything we're committed to in terms of public health, global health, clinical medicine. So that's a word. It leads to my second word, and I'll just do that now, which is herd immunity. And the notion, herd immunity, the notion that we would just go to let people get infected and that would be the end of the pandemic, has been one of the most shocking aspects of the response. And I continue to be shocked that some people would argue that that's a strategy to address a pandemic. And it's fundamentally interrelated to notions of nihilism. And as you know, very prominent people have argued for herd immunity, even from the highest levels. And again, the idea that there's nothing we can do is one that not only protects the status quo and, the social hierarchies and the incredible inequalities that the pandemic has illuminated, but it really was an idea that came out of veterinary medicine. There's this notion that, the pandemic won't end till it can't find new susceptibles. And there were many strategies for mitigation that prevent herd immunity, but the idea of projecting as a policy the notion of mass death through herd immunity as a solution to a pandemic is so, in some ways, outlandish to me that it's regrettably a keyword of the pandemic. We will achieve herd immunity, but the only way we will achieve it is really through vaccines. And that's the only way it's ever really been achieved. Ingrid.
Continue
we need to move a little quicker than.
Continue on our challenging themes here. So my next word is isolation. And I think isolation speaks again to many levels, a social isolation that we've experienced from each other, being isolated as a measure that we have to take after people test positive for COVID, the isolation of patients within the hospital setting, and of course, all of the ramifications of this on mental health and well-being. Isolation is absolutely one of my keywords.
And why don't you finish, Ingrid, and then I'll finish with my two.
Okay, so the third one I have is racism. And I mean, that has just been, again, racism has been with us for hundreds and hundreds of years, and it will unfortunately continue. Although my hope is that this, in a way, is an inflection point. It's not a coincidence that the BLM protests were so critical during this time. And I do think, my hope is for our society that we use this as a moment, and we've talked about this, that these moments of tremendous suffering can also elevate us to greater potential. And so racism is absolutely one of the words that I have for my keyword list. My last word is masks. And I mean, we had a whole session on masks, and we have continued discussion on masks. Masks have a very provocative image, and they remain deeply consequential in fighting this pandemic and mitigating its effects, but also remain a real hot button in our society. Those are my 4.
Okay, I have 2 more, and maybe then we can even get a student in. My last 2 keywords, the first one is solidarity. And I thought a lot about this. Danielle Allan brought it up when she visited the class, but if I think my first 2 words express all of my, anxieties, frustrations, outrage around the pandemic, nihilism and herd immunity. But solidarity is crucial to the way out, and seeing our connections and our relationships and enhancing solidarity seems to me to be crucially important in the time ahead, but very difficult to encourage and enhance and nurture in the face of an epidemic, especially one that leads us to often have to be isolated. And so what are the forces that create a sense of shared need and value that we do together as opposed to us versus them? How do we try to express we in a pandemic as an us, as opposed to the kind of othering that's so fundamental to racism? And these are really complicated things. Some people have said, well, during times of war, people pull together, they see a shared interest. And so the war analogies and metaphors of the pandemic, while I sometimes have some worry about them, how do we have a sense of collective mission? And that's going to be crucial, I think, to solving the problem of the pandemic. And this is why I think the course is so fascinating to me in some ways. Like, on the one hand, we have something as brilliant and as, significant as a vaccine, but without solidarity, it's going to be very hard to deliver it in a way that's fair and equitable and compassionate. And my last word is trust. And I found myself thinking through the course that when you have fundamental breakdowns in trust, you really create obstacles for public health and medicine that are just enormous. One of the things that I really appreciated in the pandemic so far was the frontline health workers. And it seemed to me it was very different than the response to HIV, where many medical people expressed incredibly homophobic and fearful responses in the early years and said they wouldn't treat gay patients. And in this epidemic, frontline health workers stood up in such brave and courageous way. And it has led to recent polls that show higher degrees of trust in our health providers today than before. And it has led to a lot of new medical school applications, what people are calling the Fauci effect. But I don't attribute it as much to his leadership, which has been fantastic. I attribute it more to the nurses and the doctors and the attendants and the people who move people through hospitals, and their courage and conviction that their identities require them to take risks. So in a way, some of the words we've discussed are interrelated. Obviously, one of the principal problems of contemporary society is trust in science. And we're going to have to take a kind of a leap to take the vaccine. And I often think about trust when I think about medicine, because, we'll go in and see a doctor, tell a doctor things we wouldn't tell anybody, and we don't know them at all. And what is that structure of trust, and can you build it? And it's something I'm going to be thinking a lot about as I think we watch this next phase of the pandemic. So I have to end this here, but Ingrid and I have some very important people we want to thank before we end the course. First of all, we want to thank all our speakers, and Yvonne put together this fantastic slide movie of all of the speakers that attended the course. And I'm just so, I'm so gratified and proud of my colleagues who, came to the class, and I know Ingrid is too.
Yeah, they were amazing. We also, all of you had a chance to have sections with this incredible group, but obviously you only know your own section leader. So we wanted to introduce you to the full team who's been working behind the scenes with us here. We'll try to go in, let's see, I'll just try to do it based upon the pictures. So Colleen Lanier. And then I think the next person is Aniki Haranan Tabibi. And then the next person is Diane Zhang. And then the next person is Emma Mendoza Broder. And I'll let you take the next row, yeah.
On the lower line is Leah Xu, Liana Rosenkrantz-Woski, who I also want to especially thank for taking the lead on the podcast assignment, and her work throughout the course was fantastic. Meg Perret, a teaching fellow, and finally, Michelle Labonte, who's been just a remarkably great colleague to work with and has been just a remarkably committed head teaching fellow, and her determined commitment to students and their learning and well-being is really just a fantastic attribute of hers. And I also want to thank Yvonne Perchukin. Yvonne, are you here?
You can try your video if you want.
You just made everything great. Of course, I want to thank Ingrid, and I want to thank all of you. This has been a just unprecedented time. There's Yvonne, who has been fantastic. Michelle, it's great to have you here. And, I want to thank you all. I just learned so much in the class, and it's quite kind of remarkable. I had a role as an instructor, but I also felt like a student a lot of times because we had so many brilliant experts come to the class. And I just have to say, like, in the end, how do I evaluate a class? I don't know how to do it, but I really learned a ton. And I learned a ton, not just about COVID, but about people and crises and emergencies and keywords of suffering, and grief and loss, but hope and possibility. So it's been a just remarkable experience for me personally. And I want to thank all of you for being such a critical part of this. I look forward to a time when you will all come see me in my office, and I'll get to meet you and we'll talk about the course. So Ingrid, I'll let you have the last word.
Thank you, Allan, and thank you all. As you all see, this is an absolute team effort, and we are so grateful to everyone. And we just want to wish you all well. We're going in to a challenging time, as we know, but also a time full of optimism. And we know wherever you are in this world right now, that you are experiencing your own COVID moment. We want to thank you for sharing in this moment with us in this journey. It's been profound for us at so many levels, and we're grateful. And as Allan said, come visit us in person anytime. We'll look forward to that. We wish you all a wonderful end of the calendar year, a safe end. Please take good care of yourselves. Know that we're thinking of you, and gratitude to Allan and this whole team. Thank you, everyone. Have a great day.
Thanks.